Hello and welcome to the Supportive Care Services Virtual Lunch and Learn series. My name is Voncel Hunter, Marketing Specialist with Ironwood Cancer and Research Centers. We've created a series of lunch and learn videos to help you be successful when navigating your cancer journey. Our Supportive Care Services Department is here to help you get actively involved in your healing process. For more information about the Supportive Care Services Department, please email socialwork@ironwoodcrc.com.
Hello, welcome everyone. I am Dr. Heidi Rula. I am the Integrative Oncologist and Medical Director of Supportive Care Services here at Ironwood Cancer and Research Centers. I am excited today for our Lunch and Learn on head and neck cancers to have our radiation oncologist, Dr. Eric Gross, join us. Welcome, and thank you for agreeing to do this.
Thanks for having me.
Yeah, so today, we're doing kind of a question and answer segment on head and neck cancers to really help patients understand what this whole kind of treatment experience would be like for someone undergoing head and neck cancer treatment. So I guess to start off, I think one of the questions that patients want to know is, kind of really explaining, what are the common treatment approaches to someone who has head and neck cancer? What are the different modalities that are being considered for treatment?
For the most part, the treatment team is made up of a surgical oncologist, radiation oncologist, and a medical oncologist. And so for invasive cancers of the head and neck, which could be anything from the nasopharynx to the tongue, so the nasopharynx being the area up behind the nose, really it's generally either surgery or radiation. One of those two treatment options, or a combination of surgery, then radiation, or sometimes radiation and chemotherapy. So it really depends upon the presentation, for the recommendation of what we do and the sequencing and the combination.
So can you explain to patients why radiation has been such an advancement in the treatment of head and neck cancers, and kind of, what it actually does and how it, it treats that cancer?
Yeah, so when you think about head and neck cancer, historically, surgery was the primary treatment option before we had the option, of radiation, or at least radiation the way it became more advanced in the last couple decades. Surgery anywhere in the head or neck region, can have a lot of side effects, can be very morbid just because of the anatomy, the sophisticated anatomy of the head and neck region. So radiation not only is done, as an adjuvant to surgery to help reduce the risk of a recurrence when surgery is unable to completely remove all of the disease, or it can be done in place of surgery. And many times the functional outcome is going to be improved if we do primary radiation plus or minus chemotherapy in place of surgery. And then sometimes we use surgery as a salvage. One example I will give you is when patients have cancer of the larynx. Historically, if you have cancer of the larynx and you have surgery, then you remove your vocal cords. You can't talk anymore. So, now many times we use chemo and radiation, and the outcome is better functionally, with surgery for a salvage if that cancer were to recur. So radiation works by damaging DNA. The simplest explanation is radiation is energy that's deposited into tissue. It damages DNA of rapidly dividing cells, which tends to be the cancer cell. And because of that, that cancer cell cannot divide. If we combine chemotherapy with radiation, it's considered sensitizing. So the cells actually are more susceptible to the killing effect of the radiation when we add chemotherapy.
Right. So one of the questions that I, hear from patients a lot of times is, they're concerned, that, they have, a cancer that's being treated with radiation, and they're worried about all the other structures and tissues kind of around that area that's being radiated, and how are those tissues impacted, and how is radiation able just to kind of focus on the cancer?
Yeah, it's really based on, advancement with software. So the more advanced software that we've had based on the more advanced computers, It's very sophisticated. Many times for the anatomy, we'll fuse MRI, to give us the more detailed anatomy, but all of our treatment planning is based on a CT, a CAT scan. The same issue arises with surgery. You have a lot of cranial nerves in the head and neck, which give us the ability to close our eyes, smile, not leak when we're drinking water, things like that. So the same challenge for surgeons, if you have a cancer, let's say of the parotid gland here, trying to preserve your nerve function here, well, when we have a cancer around the gland, we have to try to preserve your salivary function. And so it can be very challenging. Head and neck anatomy, again, is some of the most sophisticated in the body. And so with the use of not just MRI sometimes for fusion for treatment planning, but also the treatment planning that we use based on the computing ability today is called IMRT. There's a lot of acronyms in our field. So IMRT stands for Intensity Modulated Radiation Therapy. And so really it's very sophisticated planning, which allows us to deliver the high doses required to sterilize tissue, but it has a very rapid dose fall off. And so especially in the head and neck, one of the early sites that we started really exploring IMRT was in head and neck, because you may have a tumor right up against the vocal cord, you may have a tumor right up against the salivary glands. I think the biggest benefit has been reduction in long-term salivary gland dysfunction that can relate to dry mouth and subsequently dental issues or issues with the jawbone.
Yeah. So what would kind of a typical treatment course look like for somebody who needed radiation for their head and neck cancer? What should they expect, a treatment course to be in terms of frequency, length of therapy, that type of stuff?
So a lot of patients, when they come in for the initial consultation, they think that they're getting radiation that day. The radiation planning is very sophisticated, and I prepare everybody for the potential toxicity or side effects from head and neck radiation, which tend to be a little more pronounced if we do chemotherapy. But it really depends on, again, the combination of the sequencing of what we've done. If a patient's had surgery, for instance, if we have disease somewhere in the neck, and they've had the bulk of the disease removed, so we're treating just potential microscopic residual, then radiation may be 5 weeks. It's every day, it's Monday through Friday. It takes about 10 minutes a day. Where you come in, the initial thing we'll do is we do a CT scan that's called a simulation. So we're simulating the actual treatment position that you'll be in each day for treatment. We do make a mask, which is called an aquaplast mask, which is warmed plastic that then molds around the face. It kind of holds patients in position for, again, that precision with our delivery. Many cancers that arise maybe in the tonsil or the base of tongue, or again up in the upper part of the pharynx, we call it nasopharynx, or even below the larynx is called the oral hypopharynx. Many times surgery is not possible. So if we're treating the primary tumor, the treatment course may be as long as 7 weeks, where it's, again, every day, Monday through Friday. It takes about, for the actual setup and delivery, it's about a 10-minute appointment each day, and it's the same time every day.
So I know you talked a little bit about, just dry mouth and salivary function as being kind of one of the issues that head and neck, cancer radiation therapy can impact. What are some other common things that patients experience in terms of side effects of this type of treatment?
So for many, it's very difficult. The inside of the mouth is mucosa, and so you get a mucositis that can be very, very painful. If you ever had a canker sore, you know how many nerve endings we have in the oral cavity, and so the mucositis can be very, very troubling for patients. Where sometimes it will impede their ability to swallow or even get proper calories in, so they start losing weight. That's the biggest issue while on treatment. Sometimes if a patient's already presenting with more advanced disease, we may put a tube that goes into the stomach. We call it a feeding tube. It's generally temporary, but it helps the patients get the calories in and then maintaining, their weight. When you lose weight or you already present with weight loss, your body's in a malnourished state. And when you have side effects from radiation and or chemotherapy, it's more difficult for your body to repair, some of that tissue damage. And so the side effects tend to be more prolonged or more severe. So I think the swallowing issues, so sore throat, the inside of the mouth can be painful. The dry mouth can be irritating. Sometimes patients report loss of taste. We try to encourage maintaining swallowing as much as possible. So we try to help to facilitate that with some medication. But, as with any side effect from a treatment like radiation, I remind patients that everything we do for the most part is to try to make it more tolerable for them to complete the treatment as prescribed. But the ultimate resolution of the side effects won't be until we're done with the treatment.
So I guess there are, you talked about you give them some type of, therapies or treatments that they can do to maybe help with this mucositis. Can you kind of speak a little bit to what are the different things the patient could do to kind of deal with kind of the pain in the mouth from the mucositis, or even the dry mouth, those type of things?
Hydrate. I mean, it's paramount, that the patient is ingesting copious amounts of water daily. We usually will encourage them to carry a water bottle to remind them that they need to keep drinking. We use just a swish and swallow. Usually it's a baking soda with some salt, just a mixture to try to help clean that out. Because with the dryness, you also get very thick, viscous mucus that develops in the oral cavity, and some patients find that very troubling. It can be very difficult. Sometimes they just have to kind of remove it manually. Some patients report nausea related to that. When a patient's receiving radiation, then they're seen weekly. We call it an OTV, or on treatment visit. So all patients for all radiation are seen once a week. These are the things that we talk about, and I look at the weight. Sometimes when patients are dropping weight and they're having difficulty swallowing, we'll give them IV fluids, and many times they feel a lot better just with IV fluids. Again, encouraging that they continue to swallow if possible, because movement of the muscles here, helps for long-term, swallowing difficulties. We have to look at their caloric intake. Sometimes we have to counsel them on Boost or Ensure, some types of supplements. Usually I'll have a dietitian or nutritionist here in the practice reach out to them, especially if they end up having a food tube placed, because then they're going to need help with, how much do I ingest? Keeping the oral cavity clean. It's hard to brush sometimes. We have to talk about techniques to try to keep the oral cavity as clean as possible. They can have neck. Usually it's on the skin of the neck, but they certainly can have a dermatitis that can be very pronounced, from a tanning appearance to more redness where the skin can actually peel, flake, or itch. And it can look, actually, patients, they say, well, I'm burned, I'm getting burned. But unfortunately, because the area at risk would be the lymph nodes in the neck, and it's just below the very thin skin, the skin ends up getting the full dose of the radiation. And again, that's something that looks worse in the short term than it really is long term, because for the most part that does resolve.
Are there things that they need to put on their skin, during treatment to either prevent it or treat it as it occurs?
Yeah, so here's where I send it back to Dr. Rula. It's really a feather in our cap to have an integrative oncologist here on staff that can help with, some of these side effects, because you end up having suggestions sometimes that, I haven't considered. And so as I've learned from Dr. Rula, calendula really, is a topical that has been proven to be superior to Aquaphor, which is what we usually hand out. And I just tell patients whatever's easiest. Sometimes we have samples we hand out. I think overall, there's certain patients that are going to exhibit more skin sensitivity and hence more reaction. Again, you're optimizing the health of the skin and its ability to repair, but the skin reaction comes from the radiation, so ultimately it won't resolve, until we're done with the treatment. So usually it's a combination of some type of moisturizer, Aquaphor, calendula. A lot of people use aloe, although we don't have data really to support the benefit of using aloe. If it itches, sometimes we'll add a steroid. If it actually starts to break down or weep, That's called moist desquamation. That just means the layers of the skin are kind of getting down to what we call the basement membrane. In that setting, there's something called Domboro, which is an over-the-counter solution that they use these soaks. That's very effective. Or sometimes we use a prescription called Silvadene, which is many times used for patients that have actual skin burns.
Mm-hmm. How long does it typically take, for the skin to heal after kind of radiation is done? What can a patient expect in terms of recovery from those type of?
I usually say it's about the 2 week to 2 month time frame. Where the day that they're done, there's sometimes a little bit of a lag in the extent of the reaction they're going to experience. So they may not experience a significant change over 7 to 10 days, but kind of at that 2 week mark, many times the darkness, we say it's hyperpigmented, that starts to flake, the new skin comes in, it's a lighter color. The acute, real painful, kind of like a bad sunburn, that's generally present for no more than probably 7 to 10 days at the most. That's when it's most uncomfortable. There's also these gel pads that sometimes we hand out here that if patients have an area that it feels really hot, then we use these gel pads in the fridge and rotate them, and they can just kind of put it on there and keep it on there for some relief. But fatigue, the side effects, the acute side effects should resolve. The long-term side effects, things that we need to watch for. Fatigue, there certainly can be somewhat of a lag. I think fatigue is one of those that sometimes patients hit their low point after they're done with radiation and or chemotherapy. And I think it's a slower resolution long-term, where it could take months before they're back to baseline. From a long-term standpoint, things that we look for from a side effect, long-term side effect standpoint would be we need to make sure that they're seeing their dentist minimum of 2 times a year. I prefer 3 times a year, because when you have a change in the saliva, the dry mouth can increase risk of cavities. If you have increased risk of cavities, or you have any teeth that become diseased or need extraction, it's difficult when you have a jawbone that's received radiation, because that can lead to some side effects if you had to actually extract any teeth. So again, prophylactically making sure that the teeth are well cared for. Thyroid function, for most patients, that's going to start to decrease. So over time, we need to make sure that we're checking that the thyroid's working okay. And then overall, it's just making sure that the cancer doesn't come back. And it's usually about a 2-year window when you're most concerned. And so follow-up in that first 2 years is every 3 months. And it's usually between myself and then many times the head and neck surgeon. We go back and forth, plus medical oncology. So it's usually physical exam, looking in the oral cavity. Sometimes we use a scope to look back into the areas that we can't easily see. The neck is actually pretty easy to examine. And so the neck is about as reliable long-term as imaging is. And usually we'll get, imaging, whether it's a PET scan or a CT scan, again, depending on, the extent of disease up front. But we don't always image them beyond that. It's just based on the clinical, presentation with the follow-up.
A lot of patients, have some fears around getting radiation therapy about the risk of, future cancers. Can you speak a little bit about that risk with receiving radiation to the head and neck area?
It's very, very important that patients optimize their lifestyle. That's one of the things that when we work with Dr. Rula in Integrative Oncology, she works with them about optimizing lifestyle. Many of the cancers that we see today are not just related to alcohol use or tobacco use, but there's this human papillomavirus. Now we're seeing more what we call HPV-related head and neck cancers, which generally carry more favorable prognosis, but we're seeing it in a population of individuals that historically we didn't see this in. And so optimizing lifestyle, that's smoking cessation, restricting alcohol intake, healthy diet, exercise, adequate sleep is something that overall is overlooked, with a lot of patients. And so the gist of your question again was,
are there other cancers too that in terms of, does getting radiation put you at risk for getting another cancer outside of the initial cancer you're being treated for?
So it does, but what is that risk? it's hard, there's so many things, cancer is multifactorial. And so, when you have patients that have these other risk factors that I mentioned, how do you isolate the patient that's had radiation and say, well, if they have a secondary cancer, is it related to the radiation, or do they continue to smoke? Are they still at risk based on their, lifestyle, their previous behaviors? So, unfortunately, when we're faced with invasive head and neck cancer, treatment options are limited from a curative standpoint to either surgery or radiation. And unfortunately, all of these have some serious, relatively rare to serious side effects. When you think of the issues with surgery, you always have to think about anesthesia, risk of infection, risk of bleeding. From a radiation standpoint, radiation-induced cancers are probably on the order of, the risk is 0.5% per year, and so it's really the decades beyond the treatment that, you may have a little higher risk if you're a younger individual. But what I remind all patients, because it's scary to hear that, if I could get cancer from the treatment up for my cancer, but what I remind all patients is that the greatest risk to your longevity is the cancer that you currently have.
Absolutely. So you talked a little bit about fatigue, as being, an issue during treatment. In your experience, is the fatigue something that happens like immediately when somebody starts radiation? Is it something that really kind of progresses throughout the weeks that they're undergoing radiation? What can they expect in terms of their energy levels while they're undergoing treatment?
So fatigue, what I say with radiation is it's universal but highly variable. Again, patients that are starting, patients that have a more sedentary lifestyle or maybe overweight, may experience more fatigue because they're just not as active. I also have a saying, inactivity breeds inactivity. And so it tends to be with radiation, it tends to be a cumulative effect. And so patients will not experience it generally the first day. It tends to be within that, third to fourth week. Plus, if they're getting chemotherapy may affect, for instance, their red cell count, where they become, anemic, and certainly anemia can factor into fatigue as well. And the other thing that I'm sure Dr. Rula can attest to is, I don't know that all patients, and I try to prepare the patients for what's to come, is the psychological stress of the process. From the initial symptom to the diagnosis, they kind of go on this journey where they've all of a sudden been told, you got to see this doctor, you have to do this, we have to do this, and it's just this trial by fire that all of a sudden it takes on a life of its own, and it's really a loss of control. It can impact their ability to work. They have to think about financial stress, relationships. So I think that also factors, and I think the psychological stress of the process certainly translates into physical fatigue.
Yes, most definitely. I mean, we obviously that's kind of a big area that I, touch on with patients that, when you get that initial cancer diagnosis, it's just, you're just bombarded with, appointments, and you kind of, for many, are stepping into a medical world that they never really had kind of any exposure to before. So it's all foreign language, to them in terms of the information that they're hearing. And, they do, there's definitely that loss of control issue. They no longer are in charge of their own schedule. So, some of the things that, I just tend to work with patients on are kind of finding the things, the areas of their cancer that they can, control. So, sometimes, working on just, being good caretakers of their body, so being able to kind of continue to exercise, again, a lot of times that has to be modulated as to how they're feeling, but we know that physical activity under treatment, whether it be chemotherapy or radiation, can help with energy levels. And so kind of sometimes that's something in looking at their nutrition and, having them kind of, take some charge of that nutrition piece, and then, really kind of finding some type of relaxation practice that can help them, through a very trying time, because we know, once you get that cancer diagnosis, you're under incredible amounts of stress as your brain is trying to really kind of process what this diagnosis means for you. And so, that means that every day trying to work on something, that's going to kind of dial down that stress a little bit. It certainly can help modulate also some of the side effects and symptoms you experience. When we're hyper stressed, everything hurts more, we're just really, much more uncomfortable, our energy levels are down. And so, if we can kind of manage that stress, a lot of the times, the experience of, undergoing treatment is a little milder and more tolerable. So yeah, definitely. I would definitely agree with you.
And even the tools that we have to manage stress, mindfulness, even the resources we provide, or the apps on your phone. You can have an app that will help you go to sleep. You can have an app that during the middle of the day, find a quiet place, meditate.
Absolutely.
Even help some of us professionals.
Yes, absolutely. We all need to kind of dial that down. Yeah, and I do, I always talk to patients a little bit just about this whole concept of guided imagery, that's kind of an evolving field in medicine. They give it a fancy name, psychoneuroimmunology, but it really is, saying that our thoughts can modulate kind of our physiology, our immune response and everything can be affected by kind of our thinking. So that's kind of a relatively newer concept that we used to say things were all in your head, but now we know our head is connected to our body, and so that we're having more and more science that actually shows us that indeed is the case. So again, there's all kinds of like guided imagery recordings that patients can get for cancer and radiation therapy and things that really kind of just take their mind on this healing journey. I say it's it can be something where you can actually kind of have some control over some aspect of your care, when you kind of engage in some of these type of practices, because so many other parts are kind of being dictated to you as go here, go there, but these are things that you can kind of engage in and have control. And so a lot of times that can be helpful for patients. And I think definitely no harm, and there's certainly a chance that it can be very healing. So anyway, I think those are things that patients can kind of think about kind of when they're going through these treatments. So yeah, so I think in terms of just nutrition questions, do you have patients that come to you and kind of want to know exactly what they can eat, or do you kind of give them any kind of guidelines other than we talked a little bit about sometimes needing a feeding tube, but are there any foods that they shouldn't eat that they should eat? Is there any kind of guidelines you give them with nutrition?
Sure. So it really depends. When I meet with them once a week for this OTV, this on-treatment visit, you look at their symptoms. If they have the mucositis, then you want to stay away from spicy, anything very hot, anything very cold. If they're having problems with taste, many times it's going to be smaller volume but more frequent meals. Fortunately, again, we have a nutritionist, dietitian that we can engage here. I'll turn it over to them to kind of work with these patients, because everybody has also different levels of ability to kind of deal with this stuff. Sometimes patients just don't have resources. They have limited social support. If I'm looking at a patient from an unhealthy diet standpoint, I think the most important thing to recognize is that they've developed this eating habit over many decades, and it's not going to change overnight, nor does it have to. I mean, they don't have to make a complete 180, and many cancer patients that are newly diagnosed have this call to action and they want to do everything right away. And the reality is, if they set themselves up to fail, just based on the goals that they set, then outcome is going to be poor. So I try to say, just look at your diet. I try to stay away from just processed. I try to get them to think of, trying to incorporate, healthier alternatives, and then also make sure that they understand that eating healthy takes effort. I mean, it's not something and especially getting over that initial hurdle of you have to go to the store, you have to read labels, and it initially takes time, and you have to have healthy alternatives nearby, because if you get hungry, that's when you will make poor food choices.
Yeah, I mean, I certainly work with our patients too on nutrition, and I mean, I think I'm similar to you in terms of what I counsel patients on. That many come in, as soon as they get that cancer diagnosis, and they want to change everything in their life to make sure this cancer never comes back. And I'll say, let's take this whole kind of cancer treatment, in steps. In each step, let's focus on something different. And when they're going through radiation therapy, I said, let's just really kind of focus on getting you through that. What you can eat may change. You're going to have all these limitations of what you're going to eat that maybe are different than kind of your normal diet. Maybe just because things are difficult to swallow, or things don't taste right, or again, you have low saliva, so you want to eat things that are more moist. And so again, with all of that, you don't want to add all these, kind of other restrictions on now in terms of, making sure that you don't have anything with any sugar, or making sure, again, sometimes people get very, anxious about those type of things. So I say, right now we're just trying to find food that you can get in you, that, maybe the best quality that you can in terms of where you're at, what your resources are, who's around to help you kind of, with that, with getting food around. Sometimes people have family members that will make all kinds of things for them, all kinds of wonderful recipes. And sometimes people live by themselves and are very limited in terms of what they can do, whether financially or just whether they feel well enough to, to do that food prep. So try not to make too many, high goals for themselves for food. I said, we can kind of look, once we kind of hit that survivorship phase of maybe starting to make some, some continued healthy changes at that point, and, really kind of maybe dig in a little bit more. But right now it's like just kind of getting through something very difficult, and not kind of making it, this huge, additional challenge. So that's, so I think, in that way, I kind of give them a similar counsel that you do. That don't try to figure it out all on day one. We have, this is a lifetime journey of kind of trying to be the best caretaker you can of your body. So, one of those other controversial topics that also always comes up with radiation therapy is the use of dietary supplements. That a majority of patients are taking some type of dietary supplement when they get a cancer diagnosis, and sometimes people add on things when they get that cancer diagnosis because they're trying to see if they can do some things to help, maybe treat their cancer, as well as doing some of the other conventional therapies. So how do you counsel patients in terms of the use of these supplements while they're undergoing treatment?
So ASTRO is the governing body for radiation oncology nationally, and they put out a consensus statement that I, for the most part, try to abide by, and that's just that there's a lot of unknowns with supplements, and when you're delivering radiation, we know that based on the environment of the cell, that in theory it's better to just not take any supplements during radiation just because of the unknown interaction, and we're concerned that potentially some of the supplements could actually make radiation less effective, and that mechanism is pretty detailed. But so I generally will tell patients from the day that they start till the day that they're done, which might be that 7-week time frame, just eliminate taking any supplements, and then they'll sometimes want to go through one by one, and I say, okay, a multivitamin is fine, and many times they'll be taking calcium or vitamin D. I said, I think that's fine, but I've had patients bring me supplements with instructions written in Chinese before, and my Mandarin is very, very, very limited, so just the most conservative approach is just please refrain, but for the time you're on, but the last day when you're off the machine, boom, you can go and resume your previous supplements.
Yeah, I mean, I think that I kind of similar in terms of just trying to really be a minimalist during this time, because there are some studies out there that show if you use high dose antioxidants during radiation, that maybe you have poorer outcomes than if you didn't. And so there's some studies that refute that, some studies that kind of show that. So we don't have kind of a definitive answer on that. And so from that physician, it's probably best to kind of, stick with the greater side of caution, especially when you're trying to, get a curative intent, with these treatments. You want to, make sure that you're optimizing the efficacy of these treatments and not doing anything that might counteract their efficacy. So I know so many patients, are very excited about, trying some of these therapies that their friends and family have kind of sent their way as being kind of the thing that's going to help them cure their cancer. But I mean, definitely, waiting until, after kind of radiation is done is, kind of probably the safest time to look at, introducing any of those type of products. So,
right.
But yeah, I know that's what about just drinking alcohol while you're under radiation therapy? I mean, is that something that is an absolute no-no? Do you say they can have some? What do you tell patients?
Again, for some that is part of their routine, or that's part of how they relax or de-stress. I'd prefer that they didn't. Alcohol can be very drying, even to the mucous membranes, and then you're never sure if they're truly, limiting it, in moderation to that 1 or 2 drinks. So I generally would recommend that they refrain. I absolutely, recommend that they consider smoking cessation. It's very difficult to consider, continuing to smoke. Your treatment certainly could be less effective, and a recurrence of head or neck cancer, especially if you've had chemo or radiation therapy, it can be disastrous. I mean, it can be a very, very difficult disease to treat. Even in the setting of an incurable cancer, it can have a lot of morbidity. So thinking about the future is now's the time to really consider smoking cessation.
Yeah, I mean, it's so important, obviously, in kind of long-term survivorship for a head and neck cancer patient. And we do have, resources here, at Ironwood. I work with patients on smoking cessation efforts. There's numerous medications that sometimes can help with the desire to smoke. Because obviously sometimes that can be a very strong addiction to kind of, put down. Complementary therapies, there's like, auricular acupuncture, putting some, small little needles in your ear. There's different protocols that have been created that have shown some efficacy in helping patients abstain from smoking. So just really kind of encouraging patients who are struggling with stopping topbaco to kind of seek resources. Sometimes their primary care doc, their medical oncologist, and again, our department here at Supportive Care Services can also be a resource for that. But yeah, so critical, right, in terms of that long-term survivorship. And I mean, do we have studies in terms of just the actual efficacy of the treatment itself if they smoke? I mean, do we know that that we actually see poor outcomes in the short term if they're a smoker?
Yeah, I mean, no question. Because many times, and we see this more with lung cancer, many times the patients say, what's the point? You say, I'm at risk of getting lung cancer. Well, I got it now, so why would I quit smoking? But we have studies to suggest that your outcome, your treatment outcome, will be more favorable if you were to discontinue smoking.
Yeah.
At that time.
Yeah, so important. So, well, I think that probably, I think we've probably picked your brain enough for today, and so hopefully, people have gotten a good sense of what radiation therapy is all about and its role in head and neck cancer treatment. So I just want to kind of thank you for joining us today and giving us that great overview. So thank you so much, Dr. Gross.
As well.
Thank you for joining us for our virtual Lunch and Learn series. We hope you enjoyed this session. There will be a replay of this Lunch and Learn on the Ironwood YouTube and social media channels. For more information regarding our supportive care services classes and events, email us at wellness@ironwoodcrc.com. Thank you for spending time with us today.